Hello, welcome to all our attendees who are coming in from the waiting room right now. Give things a minute, let some folks get in. I'll welcome everyone as people are popping in. My name's Matt Shepard. I'm going to moderate today's look at 40 years of advocacy, although today's going to be more of a series of conversations than a standard webinar. The slide you see on the screen is one of probably two you will see all day, and otherwise, we're just going to have some discussion and hopefully Q&A and more discussion. Our presenters today are CMA founder Judith Stein, co-director David Lipschutz, uh, Senior Attorney Mary Ashkar, and Litigation Director Josh Norris. Unfortunately, co-director Scott Perkins is unavailable today, though we did advertise him. So David will pinch hit for him on both ends of the presentation. Before we move on, a little housekeeping about Zoom and the controls here. As with any online presentation, your audio and video connectivity are going to be at the whim of the internet. If you have audio trouble, you can note the audio section of the control panel at the right of your screen, in which you can switch to calling in by phone, which can be a more stable connection. Should anyone have trouble watching, also note that anyone who registered today is going to receive a link to the recorded presentation once it processes after we close out this afternoon. For today's live presentation, we're going to keep the attendees muted for the most part. And while we surely will never get to every question we get, we will hopefully have time for discussion and Q&A. And when we do, we can unmute you if you're brave enough to ask a question out loud. Otherwise, note that there's a questions section in the control panel, and you can type questions right into that. I'll be monitoring those as we go along today, and I can ask them of our presenters when we stop. We also have the traditional chat feature. Some of you have already found it. Thank you, Judy, for greeting people. Let us know who you are. Let us know where you're coming from. Let us know what your interest in the center is. Anything else you'd like us to know about you. For the questions, though, try to stay out of the chat and keep them in that questions panel, or frankly, I'll lose track of them. With much gratitude now to our presenters and to all of you who are attending today, let's bring up CMA co-director David Lipschutz to get us going in earnest. David, welcome.
Thank you, Matt, and thanks to all of you for joining us today. This, as Matt alluded to, this webinar is really a departure from our normal programming that tends to focus on a range of current Medicare issues. Instead, today we will pause to reflect on 40 years of our organization's work. Our aim is not just to bathe in nostalgia or engage in self-congratulations, but rather to take a look at the organization's accomplishments, divine lessons learned, and identify work that still needs to be done, and to do so in a manner that is hopefully of both interest and use to those inside and outside the organization. The Center for Medicare Advocacy would not exist. The organization would not be what it is today, and we would not all be together today on this webinar if it was not for the dedication of Judith A. Stein. 40 years ago, next week, on April 1st, 1986, Judy started the Center for Medicare Advocacy as a one-person show from a one-room walk-up office in Willimantic, Connecticut. Over the next hour, I'm going to interview Judy for a bit, and then Judy will lead a couple of discussions with other staff. First, to largely take a look back at where we've been with Mary Ashkar, an attorney who has been with us for over 20 years. And then with a nod towards what's to come, Judy will speak with our litigation director, Josh Norris, who has been here slightly more than 3 months, but brings extensive experience with him. Then, as Matt noted, time permitting, we'll open or end with some Q&A rather. So I'd like to bring Judy on up to the stage. And I will start my interview of you, Judy. I'd like to start with both your and the center's origin story. Let's go back to 1986, which was an eventful year. It's when the Challenger shuttle disaster happened. That was when the Chernobyl nuclear meltdown occurred. That's when some of us were awkwardly navigating junior high school dances.
Rub it in.
With respect to what was going on with you, what was happening? What was going on in your life, and what led you to decide to form your own nonprofit?
Well, thanks a lot. The questions and also for the lovely introduction and for my extraordinary years with the Center for Medicare Advocacy and incredible staff and colleagues. In 1986, relevant to this discussion, what was happening was that our president at the time, Ronald Reagan, had discontinued funding for Legal Services Corporation except for direct service work. And backing up a number of years, I had gone to law school in order to do legal services work. That meant to represent for free people who could not otherwise have pay for an attorney and needed assistance in our civil system in order to get their rights. And when I learned that the cuts were going to be made permanent to legal services in general, and in particular that systemic change was no longer going to be able to be done by legal services. So that would have been necessary court work, policy work was ending. All we would be able to do was to represent individuals, but if we saw a pattern of problems, we wouldn't be able to do anything about the patterns. And it seemed to me at that time, and a number of other fellow travelers, that we had to find another way to do the work than to stay within the Legal Service Corporation confines with all the strict restrictions and limitations on funding that had just come down the pike. So in a way, I want to start with declaring my extraordinary respect and therefore copying the words of Representative John Lewis. Many of us, including I, was forced to find a way when there was no way in order to continue to do legal services kind of work, to represent lower income people and to push for justice in the civil system and to make some good trouble. So that's what I started in 1986. Having intended to have a career in legal services, I had to find another way. And that way was to open a new organization, which was by its nature going to be a nonprofit law organization.
So it began as a one-woman show. At that point in time, what did you hope to accomplish by starting your own nonprofit?
Well, rather bold of me. I intended to make sure that there was access to quality, comprehensive Medicare coverage for all who relied on Medicare to pay for health insurance. I had been representing all of people from Eastern Connecticut who were over the age of 60 that needed help and were known to legal services. Nobody knew about Medicare. Folks came to us with Medicaid problems, but not Medicare problems. And not brilliant, but I came to understand that Medicare was the door that needed to be opened for almost everybody who was over 65 and had significant disabilities if they were to get access to health care. And I wanted to continue doing that work. And so boldly, I started a nonprofit in that one-room office with what was known as a total phone. And that meant that I could be on the phone and hear it ringing and hopefully get that other phone number answered as well, since it might have been a funding source. At the time, I had no funding. The Center for Medicare Advocacy was started with a loan secured by my home, and I had 7 and 9-year-old daughters. And shout out to the what was then the Willimantic Savings Institute for giving this crazy kid and notion a start with the loan. So that's where it began. The stairs were so steep getting up to the office that the guy who was coming up with a copy machine wanted to know if I really needed that before he came up, because if I didn't, he was not going to schlep up all those stairs. But I had a bold mission, and I'm happy to say that that included 2 major components. One was to advance access to comprehensive Medicare, equitable and quality health care, for all who depended on Medicare through excellent legal analysis and advocacy, and to make some necessary changes systemically. And the second was to build and maintain a caring and inclusive professional community organization to advance that work. And one, that you need that kind of a community to work together to make that kind of work happen.
So you talked a little bit about the challenges at the outset. One person, no funding. What were some of the challenges that your clients faced at the time? What did Medicare look like in 1986?
Interestingly, in some ways, Medicare, those who knew about Medicare, provided better access than it does now. In 1986, there were 31 million people relying on Medicare. Now there are 70 million. There were two parts to Medicare, A and B. It was a universal program. I could go into a room and speak to 100 people and talk to them generally about Medicare and not have to ask where they lived, what their income was, what their basic health needs were, because Medicare was largely a universal program. It did not have a prescription drug benefit, but it did have a relatively simple appeal system that individuals with advocacy could navigate. And there was no privatization of the program at that time. Just an anecdote, the Part B premium was $15.50 a month in 1986. And now for the standard Part B premium is $202.90 a month. Thank you, David. And I say standard because another thing has happened, and that is that premiums have become income-based in both Part B, and now we do have a prescription drug benefit, Part D, and premiums are income-based there too. So the program was universally applied to all who qualified, and that included older people over 65 and people with significant disabilities. And the employer-employee taxes, which were needed to pay for Medicare, were increased every year until 1986 in order to make Medicare a stronger, better program with more benefits. So that's where it stood in 1986. And it's changed, often not for the better, lo these many years, despite our very good work.
I know we're gonna talk about some of those changes when you talk with Mary next, but walk us through some of the milestones and some of the successes along the way, starting from that one-person office in Willimantic.
Well, when I started the Center for Medicare Advocacy, I came with a few cases from my work at Legal Services that they wanted us to continue. One was a case on behalf of individual and then individuals resulted in a class action who had been denied Medicare coverage for skilled nursing facility care because they could ambulate with assistance of a certain number of feet. That was a rule of thumb. It wasn't an individualized assessment of what that person needed, what that person needed was skilled care, ongoing therapy, and the fact that he had reached that goal of outwardly imposed goal of walking a certain number of feet did not mean he no longer met the Medicare coverage criteria for skilled nursing facility care. So one of the things I'm proud about and was a milestone at the time and continued throughout our history was a case called Fox versus Bowen, which came from Mr. Fox having been denied on the way I just said, on the basis of a rule of thumb. And we established the standard criteria which have held, should be held to this day, that everyone's entitled to an individualized assessment of whether they meet the Medicare coverage criteria. And rules of thumb, norms, screens should not be used to deny coverage. I think that's one of the overarching main successes of all the work of the Center for Medicare Advocacy, which has held us many years in many care settings.
Despite that relatively early success, though, we continue to see people with chronic conditions being denied care that they were entitled to and was medically necessary. Where did that take us? What did that lead up to?
Indeed, there was an inability to break through a long-standing myth that in order to get Medicare coverage, you had to show the likelihood of improvement. There was a thing that maintenance only we would hear. There's no coverage for care that's just to maintain a person's condition or slow deterioration. And that was the main reason, regrettably still often heard as a reason for not getting coverage and therefore access to care. And of course, the reason we do our work is to get people quality, equitable health care in the setting that best meets their needs. Finally, fast forward to 2011, the problems that we had been seeing about these rules of thumb and myths that were denying coverage erroneously led to us seeing a denial one day that said that Mrs. Jimmo wasn't going to get coverage any longer because the doctor had to say that she would improve every day. Well, that's ridiculous. No humans improve every single day. And what we determined was this was no longer something that could be dealt with on either through the Fox case and other litigation we'd brought. And even though we had changed the policy manual to say that rules of thumb couldn't be used, that we had to go to court on behalf of Mrs. Jimmo and 5 other organizations on multiple sclerosis, Parkinson's, National Senior Committee to Preserve Social Security, and Medicare joined us in that case, along with Paralyzed Vets of America. So you could see how much that denial for people who can't improve mattered to so many people. We were able to overcome preliminary motions in that case and came to, after long-standing negotiations, a settlement with the Medicaid agency. And improvement should never be the reason for denial of Medicare coverage and a bar to access to necessary care. The question should be, do you need skilled care, and do you meet the settings criteria under the Medicare law? So the case is Jimmo versus Sebelius, the case of Fox versus Bowen, all stand for some of the major successes of the center, which is getting standards put in place that prohibit rules of thumb, require individualized assessment, and put the prohibit denials on the basis someone can improve. Regrettably, everyone listening is saying, yeah, that doesn't it's still happening that people get those kinds of denials. But we're out there fighting, and that is the law. It's on the CMS website, it's in the policy manual, it's in the federal regulations.
So you mentioned Fox v. Bowen, you mentioned Jimmo. What I would throw into that mix, the observation status case, and Jimmo we litigated, with Vermont Legal Aid, observation
Yes,
status
Vermont Legal
case
Aid.
we did with Justice on Aging and others, but that over many years resulted in a new appeals process for some people impacted by observation. But you also touched on some of the disappointments. What are some of the unfinished business left over from the last 40 years that still irks you, still concerns you?
Well, the main one has to be that the Medicare program has been fragmented, complicated, and privatized. I would say that is really my main disappointment and my main concern for the future of the program and its ability to meet the needs of all its beneficiaries at a price that's affordable for taxpayers and that is available to, has an appeal system that is accessible and available and fair. The Medicare program is now, very, very complicated and truncated, and the privatization, both of the program and of the prescription drug benefit, is the biggest disappointment, I believe, in what's happened to Medicare. The universal program meant that we were all in the same boat and we all wanted it to rise and we all wanted it to go forward. And so we all rowed in the same direction. And I believe in that. That's called social insurance. Make it right for everyone. And that's really not the way the Medicare Advantage private program works.
So looking at some of the unfinished business that remains, what are some key lessons that you've drawn from 40 years of this organization? What are some takeaways that you would offer before we turn over to your discussion with Mary?
Well, I have to call out one more great disappointment, which will lead to that too. The home health benefit. Medicare has, unbeknownst to many, a rather robust benefit for care at home for those who qualify, and it's been almost decimated. And that's despite extraordinary advocacy on our part and colleagues' parts, and I hope we can continue to fight to make that real. We need to realize that we have had champions in fighting for Medicare, and that we need more of them in policy-making decisions, both at the state and federal level. And I'm sorry, I forgot the actual question you asked me to answer.
Sure. I mean, difficult to summarize, but what are some key lessons you've learned over the past 40 years? What takeaways would you offer folks, both here at the center and outside?
Listen carefully, right, to the person who's asking you a question. That's actually very important, I will say. Who is your audience? Are you speaking to a judge? Are you speaking to policymakers? Are you speaking to the media? Make sure you know what you're trying to get at and who the audience is so that you can be heard, because you're the voice for the almost 70 million people who rely on the Medicare program, otherwise wouldn't have a voice. Be persistent. Don't give up. It's hard to say. I just mentioned some of the things I'm very disappointed about that's come about with the Medicare program, and where it's not meeting the needs of people who want to stay home and who have chronic conditions, our key audience. But with persistence and colleagues and good partnerships, we'll keep moving this forward and not let it get worse. Persistence matters. You've heard me say before, I often say when I'm representing either an individual or a policy, well, I'm not going anywhere. The Center for Medicare Advocacy isn't going anywhere, please God. We're here. We're going to tell the truth. We're going to know the law, and we're going to have the stories. Tell the stories of the people who rely on Medicare. Give life to them, and make sure you can know the law, so that you can show why the people whose stories you're telling are eligible and entitled to get coverage under the law. Be persistent and compassion, show the compassion. You care about those people and they're entitled to coverage under the law.
Thank you. Important lessons indeed. I'll bow out for now, let you talk to Mary and then Josh, and then I'll come back in and try to elicit the last few lessons from you. Thanks, Judy.
Thank you so much. Hi, Mary.
Hello.
Good to see you.
Good to see you.
So Mary Ashkar is my almost 25-year colleague. Came to the center in 2002 and is our senior attorney. I think it's not too much to say that Mary has provided representation in more administrative law judge and administrative appeals on behalf of Medicare beneficiaries, I suspect, than anyone in the country. So Mary, let me start with some baseline questions. I went to law school to do this work. I knew that do legal service and social justice work. What brought you to the law? Why are you a lawyer?
So my story is a little bit different. I actually went to undergrad and I was a math major to begin with. I thought that's what I was intended to do. I ended up changing majors to become a political science major in undergrad. I really enjoyed research and writing, which was maybe the start of my legal career, doing that as an undergrad. And I decided to go to law school because I knew that it would open up a lot of job opportunities for me. What did I think I was going to do with my law degree? Honestly, I didn't know at first. So I ended up starting off at a general practice law firm in Iowa, which is where I'm from. And that general law firm was great. We did a lot of different types of law, criminal law, property law, tort law. But interestingly enough, I don't think the word Medicare ever came up in that in that
Surprising.
general law firm. So that's what I started off doing as an attorney.
And happily, somehow that led to, literally, we had doors to the door of the Center for Medicare Advocacy in Connecticut. What's that
Yes.
backstory?
So after I got married, I moved to the state of Connecticut, and I knew nobody. I had no connections, no background in the state of Connecticut. So I actually ended up going through a temp agency who found the interview at the Center for Medicare Advocacy. Mind you, still at this point, I knew nothing about Medicare. But the job at that time was going to be for me writing legal decisions for administrative law judges to sign. So I was going to be doing extensive case file research of the law and writing. So which are two things that actually brought me to law school in the first place, is doing research and writing. So I didn't really know anything. I think I used the magic words during my interview, which was, I love to write. That's all I needed to
Bingo,
say.
that's what we needed.
And that's why I got the job. Not that I knew Medicare, but that I love to write. And then, that temp job became permanent, and here I am almost 24 years later.
Yeah, and it's interesting because you do like to write, and we had, as I recall, a backup of hundreds and hundreds of cases that needed briefing for in the administrative appeal system. And what made you stay? Why are you still with the center these 25 years?
It's always the same answer. It's the people. The people that I work with at the Center for Medicare Advocacy is really what keeps me here. To be honest, as you just laid out, the job can be very exhausting and tiring. Oftentimes we're punching above our weight, and it can be very stressful. We're fighting a lot all the time, but we're persistent. And the people that I work with are not only just very, very good people, but they're also very organized and very persistent. And they make the job sometimes seem easy when it's not, but it's the people. Let's just leave it at that. The people I work with.
Amen to that. Our community is pretty special.
Yes.
Thank you. You help make it that way. So what is your role at the center?
So I primarily work on and I'll refer to it in different ways, but our TPL, or third party liability contract, which is a contract that we have with the state of Connecticut, where we're representing the state of Connecticut, and it's people who are duly eligible for Medicare and Medicaid. So they have a second payment source. And we are looking at those cases to determine whether Medicare should have covered those services instead of Medicaid. So that is our third party liability contract. I've also done work on our ads contract, which are individuals who contact the Center for Medicare Advocacy who don't have a second payment source and have paid out of pocket for the services that they've received. So primarily in those two categories, but both of those roles, both of those approaches have given us extensive knowledge in the appeals process, and also coverage criteria for the various services that people on Medicare receive. Interestingly, before I did this Medicare or this webinar, I asked our data manager to run a report. And since the year 2000, which is as far back as an easy data search will go, and I didn't want him to put in too much work, but since 2000, we have taken cases up to administrative law judges, 12,509 cases. So years before that, the number has to be double, but that's as many cases as we've taken in front of administrative law judges. So
and are there hundreds of us, Mary, doing that work? No.
5 doing the hearings.
Incredible amounts of work. Thank you. Go forward.
Yes. So, and I'll just give a couple examples of the cases that we do take forward that fall into those categories. The direct service, so again, the people that don't have a second payment source, as well as some of our TPL cases where somebody's dually eligible for Medicare and Medicaid. So the first case is a direct service case, somebody who does not have a second payment source. This was a congressional referral for somebody who was a resident of the state of Connecticut. And importantly, they had a Medicare Advantage plan, and the services dealt with out-of-network services. So she initially started off in Florida, where she had confusion and falls. They took her to the hospital. They found that she had a brain tumor, and they did surgery to remove the brain tumor, which was covered by the insurance plan because that was considered to be an emergency service. She was going to need to have chemotherapy and radiation to follow up. And she decided that she needed to go to the state of Utah to receive those services because that's where she had family support. her husband was not going to be able to take care of her in the state of Connecticut. So she decided she was going to go to Utah. They did reach out to the plan, the Medicare Advantage plan, who did deny prior authorization for those services. So the family knew that they were going to be going forward and receiving those services, knowing that they were not going to be covered. So she has her first chemotherapy treatment, and she has a life-threatening, an emergency situation following that. She has a horrible reaction to the chemotherapy, and she has to be hospitalized for 12 days. So after that hospitalization, the family receives a bill for $80,000. So that phone call came in. We really had to sit down and troubleshoot that one and figure out how we were going to argue for coverage for that. And we ended up taking it forward. And I think we were able to successfully argue that those were urgently needed services that she received following the chemo, and that maybe the chemo wasn't going to be covered itself. But what happened after that chemotherapy was something that the plan was required under the regulations to cover. Fortunately, we were successful getting that covered, and they ended up not having that $80,000 bill. Unfortunately, the beneficiary did pass away before we were able to get that administrative law judge decision for the family. So full time.
I think it makes 2 points there, Mary. One is the length of time it takes to go through these processes many times. And the second is something that I think you're particularly brilliant at, and that is reminding us to let's look at the law. And at that time, we were not, it was a while ago, we were not necessarily attuned to the fact that urgent and emergent were covered. And you made that connection.
Yes,
know the law.
Me and my wonderful colleagues. We always troubleshoot these cases together, especially when they're that big. But that's a direct service case. Our third-party liability cases are very similar in terms of the services, but a typical third-party liability case would be a skilled nursing facility resident who goes to the hospital for 3 nights. They have the qualified hospital stay. Then they go to the skilled nursing facility. They might receive some covered therapy services, but then they receive a notice and the coverage is stopped. So we look at those cases. A lot of the times we do identify skilled nursing services that continue to be required and coverable by Medicare. The most recent case, I think yesterday I prepped, was a case with somebody with a stage 4 wound. So their muscle and bone is exposed. That's a direct skilled service. That's something that should have been covered by Medicare and not our client, Medicaid, the state of Connecticut. So again, still gives us very good insight into the appeals process and how the contractors are looking at cases or not looking properly at cases. So it just gives us even more experience with the appeals process.
And what, based on your experience, would you change about Medicare coverage and appeals if you had that magic wand?
Yeah, if I had my magic wand, what I would change, I would streamline the appeals process. I would make it very, very easy for Medicare beneficiaries to take those cases forward. Right now, we do have a extra layer that has been added to the appeals process that is unnecessary. It's basically a rubber stamp denial. There's no additional analysis that happens. There's no additional documentation that's gathered. They just say no again. So it takes more time, it takes more resources just to get in front of an administrative law judge. So I would absolutely eliminate one of the stages of the appeals process. It's just completely unnecessary. It's another denial, and it's wasting more time, and people do not have time when they are appealing. I would also require our Medicare Appeals Council, which is the level after the administrative law judge. I would require them to issue timely decisions. Right now, we have beneficiaries who are waiting up to 5 years to get a decision after the administrative law judge. And that's not okay. Justice delayed is justice denied. So I would absolutely require that. I would also make changes to the Medicare Advantage appeal system. I would give more deference to the treating physicians in Medicare Advantage cases instead of having a doctor that lives thousands of miles away from the beneficiary reviewing the file, or some AI program overriding what the treating physician thinks is best. I would absolutely make a change to that part of the law. And then again, I've been saying this since the beginning of time as well. I would change or get rid of the homebound criteria for home health coverage. It is such a difficult criteria to meet for somebody in order to open the door for home health coverage and to allow somebody to stay home, age in place, stay out of the institutions, and receive care at home. I would definitely make changes to the health benefit, as you noted, which has been such a problem for people to get home health coverage. So that would be my my
sorry.
very bold wish list.
Yes. And so those would be based on changes. Many of them are based on changes that you've seen come about to the Medicare system during your career. For example, I just know that you have been able to get Medicare coverage for home care quite often in the past, but I just wonder if you could just talk briefly, because there's some chat about the home care benefit, how that has changed, although the law hasn't changed.
Yeah, I mean, there was the addition of the face-to-face requirements for beneficiaries, which does make the payment criteria much more difficult. But I think we've just seen people also have difficulty accessing the benefit. Just home health agencies telling people we don't have enough aid services. We can't provide, basically, we can't provide the care that is being ordered in the plan of care from the doctor. So I think people are having trouble accessing the benefit in the first place. And then the coverage criteria, I think, are just very strict to get both coverage and payment. So face-to-face has definitely complicated that quite a bit.
That is true. But we are successful when people get a fair shake at getting home care coverage if they need skilled nursing or skilled therapies. Someone is noting in the chat, then home health aides can be covered and covered in full if the skilled services are in place. That's the law. The law has only gotten better, but the application's gotten much worse.
Right.
How has the center's work driven change based on your experience to the Medicare program?
Yeah, so I would say the individual case stories that we get, the people who are calling in who don't have the second payment source, who are paying out of pocket, really have guided us in terms of what we do, what we take forward with respect to litigation, the policy work that we do. The real life stories from people really have helped shape what our priorities are at the center, and strengthen our litigation efforts, policy. But it can be anything from something small-ish, from we see the notices that people receive, the appeals notices that give you your appeal rights and the timeline for appealing. And we noticed that that was wrong. It was giving people less time to appeal than they had a right to. So that was a relatively quick fix. We were able to write to CMS and say, hey, you got to change your notice. This is wrong. And people might not be appealing if they think they've missed this deadline. So that was something that was relatively quick. But other efforts have taken quite a bit more time. I remember when observation status first became a thing years ago.
Yes.
And I remember the first phone call that we got, and somebody said, observation status, well, that's not a thing. You know, you must be mistaken. We've never heard of that before. And then another call would roll in and another call. And I remember hearing the whispers going down the hall of observation status. And then I remember all of us gathering in the back room saying, well, what are we going to do about this? And it led to litigation, and it did lead to some appeal rights. Unfortunately, observation status is still something that's around, but we were able to litigate that. But we litigate. So we had another example is a Medicare Advantage plan that was refusing to recognize G-tube feeds as a per se skilled service. It's in the regulations. You can't ignore it. A Medicare Advantage plan can't ignore it. And we had to take that to federal court to require the Medicare Advantage plans to recognize that is a direct skilled service. So again, it's the stories that we hear from individuals, and also some of the things that we're able to see in our third-party liability where somebody is dually eligible. They've all brought together a lot of experience and shaped how we move forward.
And finally, let me ask you, based on your experience and successes and disappointments, what messages would you want this audience to hear from you about this work in general and the ability to lawyer on behalf of people?
Mm-hmm. So my number one is don't be afraid to appeal. Don't be afraid of the appeals process. It's not scary. It's not intimidating. It's not a formal court case. The judges tend to be very friendly and very kind, especially if you're not represented, you don't have an attorney. It's just not a scary process. So I would encourage anybody thinking about appealing, if you think that you should have coverage for that, you should appeal those services. Second of all, I would say know the law. I can't tell you how many times a provider of services, a Medicare Advantage plan, a Medicare contractor has come to our hearing and misstated the law, made up law, that doesn't exist. So know the law and stand your ground, and insist that the judge apply the law. It happens more often than you would think. So knowing the law is very important. And third, and I think most important, is to become a Medicare advocate for the people around you, for the people that you love. I didn't know anything about Medicare starting this job, but I have been able to use it to help my grandparents who went from the hospital to the skilled nursing facility, eventually onto hospice. Help to make sure that they were getting coverage that they deserved to get. And also just now with my parents who had to make the choice between Medicare Advantage and traditional Medicare. And when they had the options laid out to them and they were told, here are your Medicare Advantage plans. And I said, no, no, you go back and you ask, where's traditional Medicare? And fortunately they did. So become an advocate for Medicare and for Medicare beneficiaries.
Well, thank you. You are an extraordinary advocate and human being, and you give it your all, and your all is quite remarkable. Thank you so much, Mary.
Thank you, Judy.
And now we're going to bring up Josh Norris, our litigation director. It's delightful to see you, Josh. And whereas Mary, thank goodness, has been with the Center for Medicare Advocacy for almost 25 years, equally remarkably, wonderfully, you have been with the Center for Medicare Advocacy for 3 months. So I'd like to ask you sort of a bundle of our first three questions. What made you decide to be a lawyer? What brought you to the center, and what's your role at the center? If you can talk about those three things.
Okay. Well, and as you've demonstrated now, Mary, I've got some big shoes to fill to follow on to, but you guys have carved such a wonderful path. So I got to be a lawyer kind of in a roundabout way. I was in my senior year of college, and a professor of mine was encouraging me to go to grad school. And I had the presence of mind at that point to say, actually, no, I don't want to do that. I'm a person of action. I like to get things done. And I'm going to go to law school because I, see lawyers doing things and getting stuff done. Plus, I always wanted to do something in the realm of social justice and civil rights. That's always been something that's sort of central to my core. And, I just think that every day that we get to do this work, no matter how, hard and difficult it can be, it's always a pleasure and a privilege to represent people who otherwise don't necessarily have a voice in these complicated and difficult systems. And so I think that's also something that's important to remember in dark times like this, where we're trying to think about, how do we carry forward? How do we do this in these dark times? As we're talking about John Lewis and the idea of, how do we make this work? How do we move forward? So when I got out of law school, I went to work for a mass tort plaintiffs litigation firm, which was actually, it was not what I wanted to do. I actually thought I was going to start as a public defender or something like that. But it was a great experience because they just threw me in, and I started, trying cases and being involved in litigation right off the bat. And so I really enjoy litigation. And right around the time that I was graduating from law school, the ADA was passed, Americans with Disabilities Act, and that professor of mine had suggested that that was actually going to be a really important thing that needed active advocacy to make its promise a potential reality for people. So, kind of putting those things together, I left the plaintiff's firm and started doing advocacy in the disability context. And the funny thing about, so the last 20 years I've been doing a lot of Medicaid litigation. I didn't start out my career going, yes, I want to be a Medicaid litigator. You end up going where your clients need you to go. And when you get into representing people with disabilities and older people, you find that it's these systems that we have to contend with, and that can, if they fulfill their promise, can provide such vital supports to people to allow them to live at home, to stay connected in their communities, to live lives of purpose. And when they don't, those systems actually can be quite harmful and perilous for folks. And so what I particularly found compelling about the center and the reason I wanted to join was all of this fabulous work that has been achieved over these past 40 years. Um, and, it sets out this great path forward because, as you point out, there's so much work to be done. And as Mary does too. That things have gotten more complicated. I mean, if I were to sort of compare systems, the Medicaid system, by and large, it's complicated in its own right, but its appeal process is actually rather straightforward, and doesn't have all of these multiple layers. I mean, it's baffling to me. Plus, there's some, fairly well-established timeframes that you have to
Yes.
move those forward. And so, that to me is something to take a look at. Um, and then the complexity of, yeah, now having two systems, traditional and Medicare Advantage, and the role of private insurers and private entities in this. So I think this is going to have to engender some creativity. Um, I think that now more than ever, and to me, so in thinking through litigation, I always bring it back to the client. Who are they and what do they need? Why are they in front of me? What is it that I'm trying to get accomplished for them? And I think that the better job we do of identifying specifically what their needs are and how this system or statute or provider can meet those needs, the better off we are at being advocates. So that goes back to your point about listening, being real attentive to what people are telling you, but then also listening to what their system is saying back to you. Do they actually understand your
Yeah.
client's needs? Are they actually understanding the problem? Sometimes that's the issue.
Can you
Uh,
make them care?
yeah, right. Well, and then this goes to persistence, right? And sort of
Hmm.
what Mary was bringing up, the idea that we do have to be bulldogs. We have to just stick at it because I know that I care about this way more than they do. I know that this is more important to my clients than it is to them. So if I just stick at it and keep going and I literally been in negotiations with state agencies before where I've said, look, I'm not going away. This is something that you are going to confront again and again and again. So we can either try and talk about it and resolve it now, or we can do it next year and the year after that. But I'm not going away. We're going to keep at this, and we're going to get this problem solved. Um, so I'm tickled to death that I'm here. I'm tickled to death that I get to work with such great, smart people. That was one of the things when I started asking, because a lot of Medicaid and Medicare folks, there's crossover. And when I
Yes.
started asking a lot of the people I know about the center, they just had nothing but glowing things to say. And so I'm just very happy to be here.
And we're delighted to have you. Thank you for that, Josh, and for being our litigation director. And I know the federal courts will open new avenues for Medicare beneficiaries with your leadership, right?
I hope so. I mean, if nothing else, we're going to try.
Yes, we
Um,
will.
And I think that, going back to what you were talking about, like with home health, to me, it's an issue of, and this is something that definitely coming out of the disability rights world, you're thinking about all the time, which is how is it that we can make these systems provide supports and services that are actually going to support people to have good lives, to actually have the life they want. Um, and home health is clearly such an important piece in that. I would also put durable medical equipment and those sorts of things because those obviously can be tools that people can use to navigate the world and stay at home and be in their community. And so staying focused on those things and trying to figure out some creative ways to apply the law and make these systems accountable and make it work. Because that's the thing, like, I think as you pointed out, like Medicare, it appeared to function better a long time ago. I think over time, sometimes these systems become incoherent. They're not actually
Yes.
achieving what they purport to achieve or set out to do. And I think as advocates and lawyers, it's our job to yank them back and say, no, you actually have to be accountable to the people that you are purporting to serve. And that's a priority and should always be the priority. And that the system needs to listen.
Well, thank you so much. I know that with you as part of the team moving us forward, that we will keep with that persistent approach to trying to get justice and access to healthcare. And I'm really so delighted that you're leading us in that regard. And now I think I'll bring the rest of the team back up.
Thank you, Judy. Thank you, Josh. Thank you, Mary. My partner in crime, my fellow co-director Scott Perkins, could not be here today, but he is here in spirit. And I have to say, it is an honor for both of us to take the reins at the center. And as Scott says, it takes both of us to even attempt to fill both of your shoes, Judy, and to try to maintain and grow what you have accomplished. We owe much thanks to many people, far too many to name here, including current and former employees, board members, partners, organizations, and individuals that have helped us along the way. And thanks to all of you who have supported the center in various ways, from participating in webinars such as this, reading our weekly alerts, filling us in on your experiences with Medicare, and helping us advocate for access and coverage, to access to coverage and care. Thanks to foundations who have supported us with grants and individuals who have given donations. Thanks to the state of Connecticut for our longstanding partnerships. We are indebted to and look forward to continuing to work with all of you. And to paraphrase both Judy and Josh, we're not going away. So with that, Matt, do we have any questions?
Sure, you'll be
that have
shocked
popped
to
up?
hear that we do have some questions.
All right.
First of all, let's start with sort of a bad news question. We had several people ask about HR 3467. You may be familiar with those numbers because it's the bill that's been introduced that would make everybody auto-enroll in MA. And people are asking, A, if we're familiar with it, B, is there anything that anybody can do about it to stop this plan?
Raise attention. Let it be known to anybody who has a local paper, particularly in a state where the federal policymakers might be inclined to misunderstand the value of Medicare Advantage. Write letters to the editor. Really small things that you may think don't matter will matter in a situation like this. Otherwise, it may just go under the rug and not get attention. The whole point of Medicare Advantage, which was originally called Medicare Plus Choice, was supposedly to provide choice. That was the notion that was spoken. And if people are auto-enrolled in Medicare Advantage, that's further limiting their choice. And I don't think people know that this danger is indeed possibly upon us. So speak out and let your congressional representatives, senators know that you don't want that. Those are the people who will make the final decision.
And if I can piggyback on
Please.
that and kind of speak to something, Mary, you said earlier, you advised people to be an advocate. Now, over the course of this last hour, we've talked a lot about using the law, and that law is our superpower. As attorneys, that's what we do. But it should be crystal clear that there are a lot of ways to impact the Medicare program. One need not be a lawyer. One need not be an advocate in your full-time role.
Right.
There are different ways to impact the system, including reaching out to your elected representatives. For Medicare's purposes, it's almost entirely federal. So your member of Congress, your U.S. senators, but you do not have to be a lawyer to advocate. And some of the most effective advocates I have ever worked with have been, for example, social workers, clinicians, people who advocate, SHIP counselors, people who advocate on behalf of their clients. So that's
And
one way to do
family
it.
members that
Mhm.
have joined us. I'm sure you perhaps know who I'm thinking of, David, at forums, spoken out about the problems that they and their family members have faced in part in Medicare Advantage plans because of care being denied or improperly limited. That kind of advocacy is probably the most important thing you can get policymakers to hear. Tell the stories, have people with the problems tell their stories if they can stand to do so. It will make a difference.
Uh, it's funny you guys led into that. I was going to bring that up, that Mary mentioned that, because we had several people who asked, what can we do to help you in your efforts? I am not an attorney. How do I become an advocate? I'm not in this world. What can I do? What resources? Where can I find things?
Well, Mary, you
Mary?
want to answer that?
Yeah, I can speak to that a little bit. So just first of all, with respect to becoming an advocate for those around you, asking questions, asking them what's best for them. When it comes to traditional Medicare versus Medicare Advantage, I think that's where it all begins for somebody. So making sure that they have made the decision that's right for them. You can use SHIP counselors, your local SHIP counselors to help you with that, but really become informed and educated about the providers, what they value in terms of access to care. That's where I would say the advocacy upfront is very important, which was very important for my parents when they were trying to decide between traditional Medicare and Medicare Advantage. And then with respect to just being an advocate for somebody and the resources and where to find those things, one place that I would start is our website, which does have a lot of self-help material. It has quick guides, just a quick, here's what it takes to get coverage for the home health benefit, or here's what it takes for the skilled nursing facility benefit, all the way to very extensive self-help packets that have sample letters for a doctor to write on your behalf. So what would you want your treating physician to say to help you get coverage for these services? What the law is, what the law says regarding coverage for those services. So we have quite extensive material on our website that you can look at. And another thing too that I want to mention is when you do get decisions, appeal decisions, if you've been denied coverage for services, those decisions will actually say to you, if you want a copy of the statute, the regulations, the manual, the policies that were relied upon to make this decision, you can write to them and ask for copies of all of that. So you always have access to, and you always have the ability to get the law that was used to make the decision in your case and insist upon it, and cite to it in future decisions. Because like I said, people will create law that does not exist. So always have that law in front of you and use it, and be a bulldog, like Josh said. And I'm also not sure if I answered the question.
I, I,
Yes, you
I
did.
think you did, but I have a follow-up anyway. Maybe for you, maybe for Josh. We'll see. Maybe anybody. I can't remember who asked this. I'm sorry. What are some client options? What are options after winning a decision, but then you experience either non-compliance or poor compliance from the provider, and maybe even repeat instances of the same issue? Jimo.
Yes, that's a huge problem. I will jump in on the JIMO side. The big case we won, the settlement in partnership with CMS that says that Medicare should not be denied on the grounds that person can't improve, that services to maintain or slow decline of a person's condition are coverable by Medicare. And that's true in skilled nursing facility, home health care, outpatient therapy, and to a slightly different extent in an inpatient rehab hospital. That is the law. There is an evergreen forever page on the CMS.gov website called a special message about JIMO, which reiterates everything I just said and more. And yet we know that people are still denied Medicare coverage on the grounds that they're not improving, or they have a chronic condition, or they're stable or plateaued. All those kinds of keywords should be heard as not true. That's not the grounds for denial. That's a rule of thumb. But what it takes is perseverance and persistence. You may know that we have a weekly no JIMO column in our alert to try and keep alive the fact that this is not just something that goes away because the providers or the Medicare agency doesn't want to implement it. And we have to stay educating people and providers who want to do the right thing, and families so they can advocate and can go to a family meeting with the statement from this Medicare agency website when it supports the care their dear one needs. So implementation is extremely important. And to do that, you need to know where to look. On our website is a good place, on our weekly alerts, and bring that information forward if you're being told otherwise by a provider who says you or your dear one can't get care that is covered by Medicare.
All right. We are at our 3 o'clock mark here. Why don't we end with a big picture question? Probably something everybody on this panel can weigh in on. What do we think that Medicare is going to look like 40 years from now?
40 years?
40, since we're talking about, 40th anniversary.
Well, let's say it keeps building more and more into the Medicare Advantage space. If that were to happen, there would be no more traditional Medicare. It would not be a universal system. And the major insurance companies would be truly running the Medicare program and perhaps not providing coverage as we've just described for people who have longer term and chronic conditions, even as well as they're getting it now. I don't think the system needs to be bankrupt. I think that's not true, though you hear often that that is true. And if we stop spending extra money, overpayments on the private Medicare Advantage plans, and put that money back into the traditional program to expand coverage and benefits, we'll have a much stronger program in 40 years, both in terms of its fiscal stability and the benefits it's providing. David, you want to?
Well, I was just going to say, yes, in conclusion, as we are looking to ramp up to our annual conference, our summit on May 20th, I encourage you to register for free. You can watch it online. We'll be grappling with a lot of issues and challenges to the Medicare program and the healthcare system writ large. But at risk of further embarrassing Judy, I encourage you all to take a look at her keynote speech that she gave last year, which is available on YouTube, in a speech when she entitled "Hope is a Strategy," which she wrote in response to a presentation she had recently heard titled "Hope is Not a Strategy." And if you want to hear more about kind of the lessons that Judy has learned over her career, in addition to what she's talked about today, I encourage you to check that out. And again, thank you all for not only attending today, but for all of your support for many years. It's much appreciated.
Yes, thank you so much. Thank you for those who are listening, this team and the rest of our most extraordinary Center for Medicare Advocacy community and collaborators who make a community that marches forward and is determined to make things better. So thank you so much.
All right. Thank you guys so much. Thanks to all of our awesome presenters. It was great to hear from you today. I love this format. Fantastic conversation. A reminder to all of our attendees that there will be a link coming to you, so you can check out the recording of today's presentation, pass it on to others, etc. And as David mentioned, please stay tuned to our website and alert for information on upcoming presentations, including that National Voices of Medicare Summit, for which you can register right now. Thank you all again, and I'll now close out today's presentation.
Thank you.